All right, so let's start with the first question. So hold on, let me make this a little bigger. Okay. Okay, so question one, and mind you, these are some things that maybe we have not reviewed yet in the review, but because so many of you are about to go take your test, I just want a chance for us to get questions in so I can give you quick things that you can memorize and use when you go take your test, okay? You know, okay. On the third postpartum day, the nurse would expect the lochia to be. What would you choose if you were taking your NCLEX or exit
B.
exam?
Miss Alexandra,
B.
can you put up the page a little bit, please?
Okay, okay, hold
Please,
on.
thank you.
Because I don't want to show the answer, so let me try.
Oh, okay. I didn't know that. Sorry about
No,
that.
it's okay. It's okay. Can you see it now?
Yeah, I see it.
Okay. And we'll just spend let me give you 1 minute to tell me what the answer is, and then we're going to keep going because I would like to get as
B.
many questions done as possible. So, what would you choose if this was your exam day?
B.
You said B as in boy?
Yes.
Okay, let's try again. I want you to think okay, so what is lochia?
Lokia is the liquid after you have a baby.
Very good. So, write this down.
It's
Lochia.
supposed to be like red, like your period,
Yes,
kind of.
very good, very good. So write
Start
this
making
down.
my way down.
Lochia, lochia is the vaginal discharge after giving birth.
Hmm.
It's blood. It's blood
Hmm.
and fluids and like placental debris, like the
Hmm.
little tiny pieces of placenta. So, okay, as a nurse, I want you to think like how nature works. Do you think in the beginning, like the lochia should be really dark and then get really light? Or do you think it's going to start really light
No.
and get really dark?
No, it should be like reddish, dark. I'll say
Very
reddish,
good.
First day.
Okay, so now that
reddish.
you said that, what's the answer?
Ruby, Rubra, Rubra.
Very good. Very good. Very good. So, Lochia rubra. So the order of it should be rubra serosa alba.
Ooh, mute.
Okay?
B. Chewota.
Yes, rubra serosa alba. So rubra is like a dark red.
Hmm.
Serosa is like a pink.
Hmm.
Okay, and then alba is like a more yellow white. Okay,
Hmm.
so rubra serosa alba.
Hmm.
Okay, so rubra, it should be from after delivery to the third day. Serosa is days 4 to 10, and then alba is like after day 10 up to 6 weeks postpartum.
Hmm.
Um, why is D wrong? Is D a type of lochia or is that like an amount?
Cunt.
I don't know.
Is it
It's an
order?
amount. Very good. So D is wrong because the word scant, it means a very little amount of something. So
Or
that's not a type
discharge.
of lochia. Very good. Okay, rubra serosa alba. Now, what should lochia smell like?
Uh,
Should it
Fishy?
smell like a normal period blood?
No.
Mm-mm.
Yes. Yes.
Fish,
So make sure
fishy?
you know
No.
that.
Lokia.
Lochia should smell
Normal.
like
Like
normal.
a fish thingy smell like.
No, lochia should smell like a normal menstrual cycle. It should smell like
Mm.
a normal period. So if it has
Oh.
a foul odor to it, that indicates infection.
Infection. Okay.
Okay,
Oh,
it
no.
should lighten in color over time. It should decrease in amount over time. When the woman gets up to walk, there might be a sudden increase in it, just like with your period. Okay.
Mm-hmm.
All right, question number 2. And again, we might not have done these yet, but this is just practice. Okay. Question number 2. A pregnant client is having a non-stress test. It is noted that the fetal heartbeat rises 20 beats per minute, lasting 20 seconds every time the fetus moves. The nurse explains that.
Client is having none.
What would you choose if this was your exam? Okay, so I have a question for you. Is it good, Miss Edna, is it good if when the baby moves the heart rate increases? Yes or no?
Hello?
Hello, hi Miss Edna.
Hello?
Miss Edna, is it normal that if a baby moves their heart rate increases?
That should not be normal because
So how about me? How about if I got up and I started running
I,
around?
I have a question, Miss
yeah,
what the heck, Miss Alexandra. I have a question.
Mm-hmm,
Okay, let's say you going up the stairs, and
mm-hmm,
you walk in, and after that they check your blood pressure, and it's supposed to be a little higher because you make movements.
mm-hmm.
Isn't it supposed to be the same thing as the baby moving?
Yes,
It's supposed to be a little more because of the movement. I'm
yes,
just
yes, absolutely. So
mhm.
just like if you or I, if we were sitting down, our heart rate would probably,
that's what I wanted to say. Yeah, if you're
Mhm. That's
sitting
it.
down, you're not stressed, it's supposed to be low.
exactly. So like let's say you or I, we were sitting down, our heart rate would be like at the resting heart rate. It would be
Mhm.
like a normal. But if we got up
Yes.
and started walking or running, our heart rate would increase. So the
Mhm.
same thing with a baby. When the baby moves, their heart rate should increase. I want you to write that down. You want the
Mhm.
baby to be reactive. You want the baby to be reactive. That means when the baby moves, the heart rate increases. That is very good. That is very healthy for the fetus. Okay? So, non-stress test. Non-stress test is when we put 2 bands on mommy's belly, and every time baby kicks, we want mommy to press a button. If when she says baby kicks, we should see the baby's heart rate increase. That is very good. That is what we call reactive. So make sure you know that for your exam. Non-stress test. Every time the baby kicks, the heart rate should increase. That means the heart is reactive. It can react to the needs of the body, that when we need more energy, the heart rate increases. Very healthy. So, for your exam, non-stress test. Reactive is good. Non-reactive is bad. Okay? And we will talk about that later. When it is non-reactive, now they have to do something called a stress test. One more time, what do I want you to walk into your exam knowing? Non-stress test. When the baby moves, their heart rate should increase. That is called reactive. You don't have to do anything. Okay? But if the baby's heart rate does not increase when they move, that is called non-reactive. And that would mean they need to do a stress test. Okay, so now that we said this, what's the answer? Quickly, quickly, because we have to keep moving. What's the answer to number 2? Mr. Moses.
So it's normal. It's C.
Very good. Very, very good. Very good. So the tests are normal. There's no need to repeat or determine any results. Very good. And question number 3. So again, we may not have gone over these things, but it's a chance to practice and learn. Question number 3. Because I want everybody to participate. Mr. Moses, which stage of labor lasts from delivery of the baby to delivery of the placenta?
Is the second stage.
You're close.
Together, I think delivery of the baby is second stage. And
Mm.
huh?
So what's the answer?
Third stage.
B, very good. The correct answer is B. So let me give you a trick, okay? So the stages of labor, please this will be easy for you to memorize before your exam, okay? So you have to remember what happens at the end of the stage, okay? So memorize what happens at the end of the stage. So at the end of stage 1, you have one dilated cervix. Okay, so at the end of stage 1, the cervix should be completely dilated to 10 centimeters. It should also be 100% effaced, which means so dilate is open wide and efface is it gets really short. Okay, so at the end of stage 2, so this is where it gets really easy, but you have to memorize this trick, okay? At the end of stage 2, you have 2. You have 2. You have mommy and baby. So you see, Moses was right when he said at the end of stage 2, that's when the baby comes, right? So at the end of stage 1, you have one dilated cervix. That once her cervix is fully dilated to 10 centimeters, she can start pushing. You never want a mommy to push if her cervix is not fully dilated. It's not going to work and it's going to cause a lot of trauma. And because it's not all the way open, it can hurt the baby's head. At the end of stage 2, you have 2. You have mommy and you have the beautiful bundle of joy. At the end of stage 3, guess what? You have 3. You have 3. You have mommy, you have baby, and you have the placenta.
Placenta. Yeah.
Okay? If I could spell it right. We can, okay. All right. And then at the end of stage 4, it has been 4 hours postpartum, okay? Because that's a very delicate time. Mommy and baby are both at risk to be unstable, very unstable, like the first 4 hours after birth. So memorize this. This will take you very far on a lot of maternity questions, okay?
1 second, Miss Alexandra.
Mm-hmm.
Taking notes.
Yeah, sure. And if you want, take pictures because if you're like me, I take forever to write stuff. Take a picture, and this is recorded. I will send it to everyone.
Okay.
Okay, so take a picture so that we could get as much questions in as possible.
Mm-hmm. You go ahead.
Okay, thank you so much. Okay, next question. So these are just one of the weird questions where it's like you either know it or you don't. So a client develops complications following a hysterectomy. Blood cultures reveal Pseudomonas aeruginosa. Oh Lord, whew, Pseudomonas is smelly. Pseudomonas smelly is very life-changing. Okay, the nurse expects that the physician would order an appropriate antibiotic to treat Pseudomonas aeruginosa, such as. We're a little short on time, so we'll keep pushing. The correct answer is A. Cefoperazone is used to treat Pseudomonas. So remember that for your exam.
In a waiting room.
Okay, cefoperazone is used to treat Pseudomonas.
What that would mean, Miss Alexandra?
That's the name of the antibiotic that would be used to treat that infection.
Postomatis? Oh, you say that's an antibiotic?
Yes.
Okay.
Okay. All right. Let's keep going. Remember, guys, this is recorded. Okay. Number 5. A couple is experiencing difficulties conceiving a baby. The nurse explains basal body temperature by instructing the female to take her temperature. So now this is a good question. What would you choose? When should a female take her basal body temperature?
D.
B. B. Yeah.
You
Um,
say B as in boy or D as in David?
David.
B as in
D.
David.
Good.
D. As
Very,
soon as
very,
B.
very
soon
good.
as
So anytime you see the word basil, write that down. BASAL. I want you to think basic. The basic core of the body. So your
Mm.
body will be the closest at its consistent temperature of how it always should be when you first wake up, in the morning. So basal, anytime you see the word basal in nursing or medicine, it means like the natural temperature before you get up and start moving around. Okay? As soon as she awakens. There's one of them here that I would want you to be like, you know what, that's not the answer. Which one would you say, you know what, I'm not going to tell a patient to do that to themselves?
C.
Only one time.
See, very good. Rectally, right? We wouldn't want a patient to check their temperatures rectally by themselves, and also like, what would that, you know, what would that tell you? But anyways, so as soon as she awakens, so activity changes the accuracy of the basal body temperature. That's your core body temperature. And that is better to do it when you first wake up because it's going to help to, the more luteinizing hormone you have, that is what coincides with your basal body temperature. So that's something they monitor when somebody has like fertility issues. Okay. Number 6. Oh, I showed the answer. All right. Number 6. A client is having episodes of hyperventilation. Oh, I like this question. Okay. A client is having episodes of hyperventilation related to her surgery that is scheduled tomorrow. So, what do you think is wrong with her just from that? Read that first sentence. What's wrong with her?
Is breathing fast.
Because why?
Body type.
Anxiety.
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 anxiety
Very
because of
good.
the procedure.
Very good. Remember, guys, most of the time when you get a pre-op patient on your exit or your NCLEX, they might have some form of pre-operative anxiety. Okay. Now, if the way that you answer this question, it will let me know if I need to show you a strategy. So let's finish. A client is having episodes of hyperventilation related to surgery that is scheduled tomorrow. Appropriate nursing actions to help control hyperventilating include, please read the choices and tell me
D.
the answer.
Okay.
D.
Admission.
Okay, so far we have one D.
D. Hyperventilation. Yeah,
Take
D.
the temperature. Yeah. Administrative
Hyperventilation related to surgery.
would have right of break into it.
Control hyperventilation include using distraction to help control hyperventilation. Have to hold breath and
Hyperventilator related
keep
to her
the
surgery.
temperature in the room
Mm.
um, and high level respiratory similar. Reduced respiratory similar.
A client would have breath of break into it. Yeah.
So finally, let's see so we had a couple of D's. Any other answers?
Maybe C.
Very good. Excellent, excellent,
Mhm.
excellent. So remember, hyperventilation, she's going to blow off too much CO2. CO2 is an acid, so she's at risk for respiratory alkalosis. So hyperventilation can cause respiratory alkalosis. So we need a way for her to retain CO2 and not blow off too much of it. So C would be the correct answer. So we're not going to ask her to hold her breath for a minute, but we're going to help her to slow her breathing down. Okay? Why did you not choose A?
It says
That's
Q
the
4 hours.
she has
So
going
the
into
signal,
surgery.
the signal is not good. Can you say that again?
I did not choose A because for the procedures it's supposed to be MPO. And
Very
this one says Q 4 hours.
Very good. Excellent. And also, like, do we want to jump? Like, okay, so she's having anxiety, so we need some form of de-escalation, correct?
Yes.
Okay,
Yes.
so first, when you need de-escalation, you don't want to jump to medicine right away.
We start with non-pharmacology.
Yes, very good. I don't know if it's me. Does anybody else hear an echo?
I do.
Okay.
Yeah.
Yeah. Huh. Okay, well, I know the weather is bad, but okay, so yeah, so remember in nursing, you never want to jump to medication right away for anxiety. So I know that's why D seems like a perfect answer, but is distracting her, that's not going to help her keep her mind off the surgery, okay? But she also has the issue of the hyperventilation can lead to respiratory alkalosis. We need a way to slow down her breathing. And so first we're going to try C, okay? Now, if C doesn't work and she starts to have respiratory distress, we would try oxygen. And then as a last resort, maybe the doctor would order some type of anti-anxiety. But that's definitely not going to be the first thing, okay?
So,
So,
Professor, sorry, please.
mhm.
Because that C, the second part would have been my option because I was looking at it. But when he says have the client hold her breath, that was what threw me off.
I know.
That me too. That's what
That
I was like.
too. The first
What?
one threw me
Holding your
off
breath.
too.
You want to suffocate?
No,
That's what I would never pick that. I would
I
never pick it.
agree. They could have said it a little differently, but we're not going to have the client hold her breath for like a whole minute or something, but it's more something to just get her to slow her breathing down. So, maybe they would say like breathing through your nose and out through your mouth. That would help her to breathe more slowly. So I agree with you. The way they worded it is a little, yes, but this is a really good Q bank, and most of my students who do these questions with me succeed in what they're studying for. So it could have been worded differently. But I want you to take away from this, most of the time when you get pre-op patients on your exam, they're going to have some type of pre-operative anxiety. You want to try a natural way to help them slow their breathing down. You don't jump to medicine right away for anxiety. That's the takeaway. Okay, so now this next question is a tough question. Okay, a client delivered a stillborn male at term. An appropriate action of the nurse would be to, what would you choose?
Is C.
C.
See,
Provide an
Very, very,
opportunity
very
for the
good.
parent to
Wow,
see
you guys are ready.
and
I thought that this
hold
was going to be a difficult question. Very
the
good.
baby for
So why did
an
you choose
abuse
C?
and on the because understand. Even if the patient and the baby did not make it, the mother still have the right to bond for a few minutes before letting go.
Very good,
Yeah.
very good. So do you think that this will help with the acceptance process?
Oh God.
That's painful.
I
I
know,
don't-
That's hard. That's hard.
I know. Now,
I will use it might help for the healing process, allowing her to
See
grieve
the baby
then.
for the first and the last time.
Mm-hmm.
I mean, some people heal differently. It might kill me if I see
Yeah.
the baby. It might, make someone else
right,
feel
so that's
better
why
if
it
they see
says
the baby.
provide an opportunity, right?
Mm-hmm.
Provide an opportunity. So why did you not choose A?
Oh no,
No,
you breaking
we don't
somebody's
have,
heart.
you don't have a right to say
you,
that.
you,
Very good. And you don't know their religious beliefs, right?
Yeah.
What about B? Why didn't you choose that one?
You also don't have the right to hold
you
their
don't have the
baby.
right to forcing them not to see their baby.
And so it says that seeing their baby will assist them in the grieving process. Okay. And then what about
Yeah.
D? Why didn't you choose D?
You can't be
Not be sure.
because it's
Because
not
most patients,
cognitive.
in fact, this process for some, they don't even want to have babies anymore.
Mm-hmm.
So
And
you
then what
cannot do
do you know they can have other children?
exactly. You don't
You
know, so you
don't know,
cannot reassure
right?
what you
So
don't
we
know.
never want to
You
provide
don't know.
false
Show
reassurance.
them.
Yes, you never want to provide false reassurance. So
And they're gonna hold on to it too.
Well,
mm-hmm.
false assurance.
So this is a very tough question. Oh Lord.
Mm.
Help us, Lord. Okay, all right. Now, 8. A 29-year-old client is admitted for a hysterectomy. She has repeatedly told the nurses that she is worried about having this surgery, has not slept well lately, and is afraid that her husband will not find her desirable after the surgery. Shortly into the preoperative teaching, the client complains of a tightness in her chest, a feeling of suffocation, lightheadedness. Shortly into the preoperative teaching, lightheadedness and tingling in her hands. Her respirations are rapid and deep. Assessment reveals that the client is, what would you choose?
D.
Will be an alkalosis rapid and deep.
Just it's similar to the question we did. So you go for hyperventilating.
Very good, very good. So remember, I'm telling you, you're gonna see it. Preoperative patients that start to get nervous or afraid about something, they're gonna get preoperative anxiety, and it's gonna be hyperventilation, which is a sign of anxiety. And our priority is to help her to slow her breathing down. Okay. And then once we get her stable in her breathing, then we can assess what is making her nervous. Okay, what is making her afraid, so that we can use education to help reduce the anxiety, because most of the time they're anxious about something that's not realistic. Okay, so, okay, number 9. A 44-year-old client had an emergency cholecystectomy 3 days ago for a ruptured gallbladder. She complains of severe abdominal pain. Oh my gosh. Now, this is a true NCLEX style question. So, she complains of severe abdominal pain. Assessment reveals abdominal rigidity, distension, increased temperature, and tachycardia. Diagnostic testing reveals an elevated white blood cell count. The nurse suspects that the client has developed, such a good question.
C.
Wow.
Yeah. See.
Very, very good. I'm telling you, if you got this question right and it came naturally to you, you're going to pass. This is true NCLEX. You have to know what peritonitis is, okay? So the peritoneum is the lining of the abdominal cavity. So the peritoneum, that's what holds your intestines, okay? And so now when that gets infected, like there's infection in the fluid or the peritoneal lining, that is called peritonitis. So make sure you know that peritonitis can lead to sepsis and death. You have to know the signs. abdominal pain. The abdomen will be board-like a board, like a desk. It's hard, okay? And distended, the patient will have a fever, okay? And elevated white blood cell count.
Professor, is
Yeah,
there anything like what's gastritis?
very good. Gastritis is like an irritation of the stomach lining,
Mhm.
okay? So that's more like, let's say they ate some
And is
mashed.
that like kind of gastritis? Is this like an inflammation or something?
Yes, it's an inflammation, and think of it more like an irritation,
Mm-hmm.
especially by something maybe the patient ate, like
Mm-hmm.
bad shellfish or something. And so gastritis, enteritis, like in the intestines, enteritis, you would see more like vomiting, and they don't want to eat. Okay, so you wouldn't see like an increased temperature, tachycardia, elevated white blood cell count with gastritis. No, that's more true GI symptoms like vomiting, they don't want to eat. What's evisceration?
God, I don't know.
Is evisceration like an infectious process? Is it an inflammatory process, or is it more like a trauma? Okay, so whereas gastritis is more like an inflammation, irritation, evisceration is a trauma. Evisceration is when the intestines come out of the abdominal cavity. So let me show you a picture. I hope you're not eating, but okay, all right. It's pretty nasty. Because, okay, so what is visceral? If I say the word visceral, what does that mean?
But it's
Visceral or viscera, that means organ, right? So evisceration is like the removal of the organ. The organs is outside of the body. So let's look at a picture. Pretty rough. Okay, pretty.
It's not.
So
Yeah,
this
they
is
came out.
evisceration.
Lord Jesus.
Okay, so
What?
evisceration, the viscera have been evacuated from the peritoneal cavity. So this
Jesus.
is trauma. Okay,
It's a
evisceration.
removal.
So evisceration can happen with trauma. Evisceration can be like, let me show you what it happens with a wound. So you can
Oh
see
my
the
God.
difference. Yeah, I know. It's just really bad. I know. But guess what? Anytime things like that make me feel sad, I think, you know what? As nurses, we're going to help patients with these type of problems. Okay, so let's look at the
So
G.
it's so then it's the removal of the internal organ. Is it a
It's
removal?
the exiting. It's not the removal. It's the exiting of abdominal
Oh,
contents outside of the cavity.
oh, okay.
Okay. So let's look at a few pictures because you need to know the difference. Okay. All right. Hold on. That's a little small. Let's see. So this is one picture. So when you're talking about wounds, right? Evisceration can happen from trauma. Just like in this gentleman, that's trauma. Okay, bless his heart. And you can see severe abdominal trauma from some type of accident. Okay. Now
Oh Jesus.
we have dehiscence and we have evisceration. So dehiscence is when a wound, the edges come apart. Okay. Evisceration, the edges have come apart, and then you have an exiting of the abdominal organs outside of the peritoneum. Okay. So here's another picture. Dehiscence, evisceration. Okay. All right. And then I want you to know, I
is
want
it the same thing as protrusion?
huh?
Is it the same thing as protrusion? Like
Protrusion. What?
Mhm.
Can you say that again? I want you to see. Now, this is a good example. Okay, so you see this last picture? You see this first picture, he has a wound vac. A wound vac helps the wounds close better. So now this last picture, This is what you want. I know you see some redness though, but this is what you want your wounds to look like. When your patient has like a fresh surgical wound, you want the edges to touch. That is called well approximated. You always want the edges of the wound to be well approximated, which means they touch each other. Now, when they open, that's dehiscence. When they open and like a small intestine's popping out, that's evisceration. Okay, so now let's go back. Okay, so we're going through, this patient has abdominal pain, rigidity, distension, fever, tachycardia, high white blood cell count. So that's peritonitis. Pulmonary embolism, you would have more shortness of breath and chest pain. Okay, so gastritis is more like an irritation of the stomach. That's like vomiting. They don't want to eat. Evisceration, you will see it. You will see the intestines popping out. So that is why C is the correct answer. Okay. Number 10. Oh, number 10. This question is it's not like my favorite, but we'll do it just in case. You never know. A 35-year-old client is admitted to the hospital for elective tubal ligation. While the nurse is doing preoperative teaching, the client says, the anesthesiologist said he was going to give me balanced anesthesia. What exactly is that? The best explanation for the nurse to give the client would be that balanced anesthesia, the correct, well, you know what? Let me see if you can figure it out. What would you choose? Well, the correct answer is D.
It's D.
Yes.
Oh my God.
Very good.
Oh my
The
God.
correct answer is D. Balanced anesthesia is a combination of a number of anesthetic agents that produce a smooth induction. So like induction is when they put them under anesthesia. So yes, all right. I don't really think you would see a question like this. The peritonitis one, yes. Okay, 11. Following a gastric resection, a 70-year-old client is admitted to the post-anesthesia care unit. He was extubated prior to leaving the suite. Oh, this is a good question. On arrival at the post-anesthesia care unit, the nurse should, what would you choose? This is a good question.
Okay.
Very good. Very, very good. Remember, okay, where is this patient? Where are they physically in the hospital?
Inside the
Post-op?
post-up.
Very good, but
Post
they're in a
anesthesia care.
specific, yes, they're in a specific post-op unit called post-anesthesia
Anesthesia
care.
care units.
Have you ever heard them call it the PACU?
Yes.
PACU.
Yes.
Yes.
Post,
Yes.
Yes.
yeah, post-anesthesia
Anesthesia
care
care unit.
unit. So that means if they're in the PACU, they had anesthesia, correct?
Yes.
Yes.
Anesthesia is a central nervous system depressant. That means it puts your brain and your spinal cord to sleep.
To sleep.
Anesthesia causes
What's the data?
respiratory depression. Okay,
So that's why they are checking the airway, right?
The
Airway.
airway, yeah.
there you go. And also, what happened before he left the OR suite? What happened?
You say after he left?
Yeah, so read the question again. Before he left the OR suite, they did something. What did they do?
Okay.
Oh,
Oh,
extubated
they
him.
extubated
Yeah,
him.
So
extubated him.
yes, very good. So they extubated him. So if you extubate someone, that means they were intubated before, right?
Mm-hmm.
Yes.
So they
Yes.
intubated him. They put a tube down his throat, and that tube served as his airway while he was under anesthesia. So sometimes they do that because when they put someone under anesthesia, they would rather they already be intubated. So if something goes wrong, they're not rushing to try to intubate them. They're already intubated. They have the airway without a doubt, right? And they have the airway, they have the ventilator or the ambu bag for mechanical ventilation. So you have your airway, you have your breathing, and then they will maintain circulation with fluids and certain like vasopressors and things like that as needed. So that's how they keep a patient stable under anesthesia. Now, when it's time for the surgery to be over, okay, they are going to extubate the patient. So now, anytime a patient is extubated, they are at high risk for airway issues,
With
right?
with depression.
Yeah, you had a secure airway, but you removed it because the patient is, waking up. So that is why you want to check airway. Anytime the patient is in the PACU, the number one priority is airway.
Anyway,
Mm-hmm.
That is how you will get this question correct. Then, after you know your airway is open and you can see that they're breathing and they're breathing enough, then you will count your respiratory rate. Then you will do your pulse oximeter, you will do your heart rate and your blood pressure. Okay?
mm-hmm.
All right, next question, number 12. Another good question. So when I say it's a good question, these are things you can, like 90%, you're going to see things like this, okay? A 25-year-old client is admitted for a tonsillectomy. She tells the nurse that she has had episodes of muscle cramps, weakness, and unexplained temperature elevation. Many years ago, her father died shortly after surgery after developing a high fever. She further tells the nurse that her surgeon is having her take dantrolene sodium, Dantrium, prophylactically prior to her tonsillectomy. Dantrolene sodium is ordered preoperatively to reduce the risk or prevent what?
B.
C,
B.
Very good, very good.
B.
So anytime a question talks about that a patient, when they're having surgery, they get a fever and rigidity, that is called malignant hyperthermia, and it can
Mm-hmm.
lead to death. So anytime a question talks about a patient is having surgery, they get a high fever, muscle rigidity, this is called malignant hyperthermia. The medication given to prevent this is called dantrolene.
Tantrum.
Okay, and make sure you know that malignant hyperthermia runs in the family. So because her father had it, she's at risk for it. Okay.
What is a uh I know hypothermia is high, the temperature. The
Mhm.
malignant is just like what?
That it can be
Cancer or something?
no, that it can be deadly. That you can die. Oh, I'm sorry. Someone who has it can die from it. So that's why
Okay.
her father died.
Okay.
Yeah, I'm not talking like fever like 99.5. I'm talking like
Mm.
105, 108 degrees Fahrenheit.
Oof. Okay.
Mm-hmm. Mm-hmm.
So that's why they call it malignant because it's so high.
Yes, and the
Okay.
mortality rate for that disorder is
Mhm.
very high. So not only does it run in the family, but it's very deadly.
Okay.
Yes, very. You guys are doing wonderful. Okay, so now this next one is a bit tricky. Okay, but let's see what we can learn from it. The family member of a child scheduled for heart surgery states, I just don't understand this open heart or closed heart business. I'm so confused. Can you help me understand? The nurse explains that patent ductus arteriosus repair is, what would you choose? and then we'll learn together.
Is it C? Just guessing.
Okay, so we've
A.
got a C. Any other answers? And this is a tricky question.
I'm going with D.
Okay, we've got a D.
D.
Any other answers? Pretend this is your exam.
B. U.
So the correct answer is B. So this is what we would call a closed heart surgery. Okay. So this is how we could use a cardiac cath to do this, where they would go in through like the femoral artery in the leg with a catheter, and then they would advance up through into the aorta, and then they would isolate the problem. So let's look at a picture.
Oh, Miss Alexandra, can you leave it that big?
Okay. Oh, it was small before?
Yeah, because I was having a lot of fun reading it. I didn't say anything, but I
Oh,
just realized it can go bigger.
okay. I didn't know it was small for you guys before.
Yeah, because I don't have that best vision, so
Okay,
it's
thank you
best.
for letting me know. Thank you for letting me
Mhm.
know. Okay, so when
You're
the
welcome.
baby, you're welcome. So when the baby is in mommy's belly, they don't have to breathe oxygen like through their mouth or nose and into their lungs. Remember, they get all of their oxygen directly from mommy's umbilical cord. The baby is not truly going to breathe until they are born, okay? And now when the baby takes their first breath, there's going to be pressure changes. And there's an artery, there's a vessel, excuse me, called the ductus arteriosus that is supposed to close when they take their first breath. Okay, so you should see when they take their first breath, this is all there should be left of the ductus arteriosus, something called the ligamentum arteriosum. Okay, but when the baby begins breathing and their ductus arteriosus does not close, that is called a patent ductus arteriosus. Now the problem is oxygenated blood that leaves the left ventricle is supposed to pass the aortic valve and enter the aorta and bring oxygenated blood to the rest of the body. However, a baby with a patent ductus arteriosus, this oxygen-rich blood is going to mix in the pulmonary artery, which has oxygen-poor blood. So this is going to cause a mixing of oxygen-rich and oxygen-poor blood, which is going to decrease the effectiveness of the baby's aorta to get as much oxygen-rich blood to the body as possible. Long story short, a patent ductus arteriosus causes blood mixing and less oxygenated blood will leave the baby's heart. We can fix this with closed heart surgery. That's what I want you to take away from this question. All right. Okay. We don't use grain anymore, so don't worry about this one. We're just focusing on things that are realistic to what you're going to see. Okay. Question 15. A 47-year-old male client is admitted for colon surgery. Intravenous antibiotics are begun 2 hours prior to surgery. He has no known infection. The rationale, oh good question. The rationale for giving antibiotics prior to surgery is to, oh, so good. What would you choose?
B.
Okay, we've got one B so far.
D.
So is it
C. C.
It's either B or C.
so do we want to give antibiotics to relieve a client's concern? Is that why we give
No.
antibiotics?
No. So it's B.
No.
Very good. Like we don't give antibiotics for like somebody who's worried about something. We give antibiotics for something either to prevent something that is likely to happen or to
Right.
treat something we've identified is there, right?
Mm-hmm.
So what is the answer?
B.
Very
B.
good. Very good. Okay. So remember, after having surgery, the risk for post-operative infection is high. Most of the
Mm-hmm.
time, when your patient, when your patient is scheduled for surgery, you're gonna do your pre-op checklist. You're gonna give them a bath with like Hibiclens, change their sheets, put a gown on them. You're gonna, make sure they have their allergy bracelet on. You're gonna give any pre-op medications. You're gonna shave any areas the doctor told you to shave.
Mm-hmm.
Right? You're going to make sure the surgical consent has been signed by the surgeon and the patient and you witnessed it. Then you're going to call, report to the pre-op holding nurse who's going to hold the patient pre-operatively before they get wheeled into the OR suite. And then so when you give
Mm-hmm.
report, and she's going to tell you when to call transport to send the patient down. But every hospital is different. So after you give report to the pre-op nurse, she will say, okay, I'm going to send for the patient in about 15 minutes. So that means transport is coming to get the patient in 15 minutes. So if you need to do anything, put them on the heart monitor or remove the heart monitor because transport will put them on one, like you got to do it, right? And then you need to make sure you check the MAR, the medication administration record, for any pre-op medication orders, because they usually want, as the patient is being wheeled down to pre-op holding, that they start getting their pre-operative antibiotic. Okay, this is not for every surgery, but for most surgeries, especially like of the abdomen. What type of surgery is this patient having? What kind of surgery is this patient having, guys?
Colon
Colon
surgery.
surgery. Most of the time. And then what's in the colon? Let's be real. What's in the colon? Come on, guys. What's in the colon? Poop. Correct?
Yes.
Yes.
So they're going to manipulate the organ that has poop. The risk of a little poop getting out, peritonitis, sepsis, that's it. The risk is there. So pre-operative antibiotics will help to decrease the risk of post-operative infection. So that's why B is the answer. Why didn't you choose D?
Reduce the risk of.
Are you concerned about fever or are you concerned about
About infection. No,
Infection.
we're concerned about infection. So infection lead to fever. So
Very good, very good. So fever would be just like a side effect of a greater problem, right?
mm-hmm.
So we would
Mm-hmm.
if they had a fever, it's still a problem. We would still treat it. But in the
Mm-hmm.
case of a post-op patient with a fever, is the
Mm-hmm.
priority to treat the infection or the fever?
The
Right.
infection.
The
Infection.
infection, right? And then the best treatment is prevention, right?
Right.
Right.
Right. Okay. Okay, so 16. A 19-month-old is admitted to the hospital for surgical repair of patent ductus arteriosus. The child is being given digoxin. Prior to administering the medication, the nurse should, would you choose?
Monitor the blood pressure?
C.
Oh, I'm sorry.
The answer is C.
Very
C.
good. Very, very good. So remember, digoxin. So if you don't know this already, digoxin increases the contractility of the heart. Can someone tell me what that means?
Makes your heart beat faster?
Not
Your
faster.
dad.
It makes your heart beat more effectively.
It
Like
regulates it. Yeah.
yeah,
Yeah.
it makes it squeeze harder. Like it makes your heart squeeze harder so that like when it pumps blood out, it pumps it out harder.
Tachycardia.
So now with digoxin, to make your heart squeeze more effectively, it slows it down. Okay. So make sure you memorize.
Bradycardia.
Yeah,
Bradycardia.
yes, bradycardia. So make sure you memorize for your exam. Digoxin increases the contractility of the heart. It makes the heart squeeze harder. So it's very good for like a patient with heart failure where the heart just doesn't really squeeze the way that it should. Okay, it's going to help with that, but in doing that, it also slows it down. So we have to make sure that the patient doesn't have bradycardia. Why? Why?
Because it could make it
If
worse.
yeah.
Yes, like
Who
Woo!
ridiculous.
said that just like a cardiac PCU nurse?
Oh, Jesus. I'm going to make that money.
If you can think like that, and I know Nikisha knew it too, if you think like that, you
Oh,
will.
that's Jeanette. That's not Nikki.
No, Jeanette, but I know Nikisha was about to say it too. I saw the.
Oh, Nikki, I take my what's called? I take my credit.
Yes,
That's
yes.
okay.
You guys are doing.
I'll share it with you though, no worries.
You guys are doing great. So remember, digoxin increases the contractility of the heart. It drops the heart rate. So you want to make sure it's not already low before you give it because it will drop it even more. And then we're going to have issues with that could lead to cardiac arrest because the heart rate will drop too low and it won't be able to perfuse the myocardium. Okay? All right. Anytime for digoxin, you have to check the apical pulse for 1 full minute. Okay, 17. A 35-year-old client had returned to her room following surgery on her right femur. She has an IV of D5 and 1/2 normal saline, infusing at 125 mLs per hour, and is receiving morphine sulfate. So sometimes the dashes don't show it. That's supposed to say 10 to 15 milligrams. IM every 4 hours PRN for pain. She last voided 5.5 hours ago when she was given her preoperative medication. In the monitoring and promoting of urinary function after surgery, the nurse would, what would you choose?
C.
Okay, so we got one C. Any other question? Any other choices? Come on, what do you guys think?
Miss Alexandra, can you make it a little bit bigger, please? I can barely
Okay,
see.
okay, all
Please,
right.
thank you.
You're welcome. Let me try. Oh, what did I do?
Yeah, perfect.
What about now?
Yeah, I can see now.
Okay. Come on, guys. What would you choose?
And C.
Very good. Very, very good. So you would want to report to the surgeon if the client is unable to void within 8 hours of surgery. So she had surgery, right?
Mm-hmm.
What do you usually have during surgery that starts with an A to put you to sleep?
Anesthesia.
Anesthesia.
Anesthesia, very good. So anesthesia puts things to sleep, correct?
Mm-hmm.
It puts your brain to sleep, it puts your spinal cord to sleep so that you don't remember and you don't feel the pain.
Mm-hmm.
It puts your bowels to sleep. That's why, when somebody wakes up from surgery, we want them to pass gas because that's going to let us know their bowels woke up. And it can also lead to urinary retention. That's why when somebody wakes up from surgery, we want to make sure they pee. Okay. Also, what medication did she get post-op?
Morphine.
Morphine, very good. Morphine. What type of medication is morphine?
Opioids or narcotics.
Opioid.
Beautiful, beautiful, beautiful. Morphine is an opioid. You can also say it's a narcotic. There are 3 side effects of morphine I want you to memorize for your exam. Number 1, respiratory depression. Number 2, constipation. Number 3, urinary retention. Make sure you know that narcotics decrease respiratory rate, they cause constipation, they cause urinary retention. She's getting fluids IV, okay? She's getting D5 and half normal saline at 125 mLs an hour, usually like 75 mLs an hour, usually. That's what patients get their IV fluids at, but 125 and she's not peeing? No, something's not right. So we have to report to the surgeon.
I'm so, Miss Alexandra, this person, oh God, this person is on a line, I'll say, to have fluid overload, right? Because they did not peeing. Oh no.
Yeah, technically, yeah. Yeah, but
Mm-hmm.
really the problem is like why is she not peeing? But yeah,
Mm-hmm.
you're right. Like getting all that fluid and it not going anywhere. Yes,
Mm-hmm.
yeah, that could happen. But she's 35, so maybe not. But if anything, just the bladder will get fuller and fuller and fuller. So if your patient doesn't pee in 8 hours, you have to tell the doctor. The doctor is then gonna tell you to get a bladder scanner. It's like an ultrasound machine and you scan the bladder and it's going to tell you how much urine is in the bladder, and usually if it's more than 200 mLs, the doctor's going to tell you to do the intermittent catheterization where you put the catheter in and drain the urine out. Okay.
But Miss Alexandra, I have a crazy question. Let's say this person don't pee, right? But keep getting that fluid. What happened to the bladder? Is it like
It's going to get
is
more and more full.
is
And
it gonna overflow inside the stomach, or what's gonna happen? It's a
well,
crazy question, but I
yeah,
mean,
no, that's not a crazy question. So, when the bladder overfills with urine, the bladder has stretch receptors on the inside that respond to.
mm,
So, when the bladder fills, the bladder stretches more, and the stretch receptors send signals to your brain to let you know that you need to pee. Now, if you don't respond to that, your heart rate is. You ever been in the car driving home and you gotta pee so bad, but you're not gonna
right.
make it home in time? What happens?
Mhm.
You're sweating, your blood pressure's up, your heart rate is up. That's your body's way of telling you, hey, you really need to go pee. You're stretching your bladder, you know? And
Mhm.
now,
Mhm.
um, one option is the bladder will just find you'll just pee on yourself, okay, if you just can't hold it anymore. Now, long term, the problem is when urine starts to go back up the ureters, urine is supposed to go into the bladder and you pee it out. When the urine goes back up into the ureters and it can make its way back up to the kidney, that's going to lead to a bad infection called pyelonephritis. So it can lead to infection. So that's the major problem. So, what they're going to do with this patient is they may have to catheterize her, and then as the anesthesia and the narcotics wear off, hopefully her urine function will return back to normal. Okay. So it's most likely a consequence of the anesthesia, central nervous system depressant puts things to sleep, and the narcotics, which naturally cause urinary retention. Okay? So we would tell the doctor. And that's for any of your patient when they don't pee. Okay, next one. This is a weird question, but we'll do it. A client develops an intestinal obstruction post-operatively. I wonder why. What do you get in surgery that starts with an A?
Anesthesia.
Anesthesia. Anesthesia puts your
Anesthesia.
brain to sleep. It puts your spinal cord to sleep. It puts your intestines to sleep. So when the patient wakes up from surgery, the anesthesia should wear off. The brain should wake up. Spinal cord should wake up. Intestines should wake up. The patient, you want them to pass gas. That means the intestines woke up. But now, if they don't pass gas and they start vomiting, that's a sign of intestinal
Backed up.
obstruction. Yes, very good. Intestinal obstruction. So a client develops intestinal obstruction post-operatively. A nasogastric tube is attached to low intermittent suction with orders to irrigate the NG tube with sterile saline every hour and as needed. The rationale for using sterile saline as opposed to sterile water to irrigate the nasogastric tube is what? What would you say? Come on, guys. This is your exam. You're taking your exit. You're taking your NCLEX right now. And this question is in front
No
of
B.
you.
This is
Okay, so we've got one B. Anyone else? This is a tough one. I'm not going to lie to you. Come on, guys. Last chance. What are you choosing? Come on. The time is ticking and it's time for you to, you got to go to the next question. What would you choose? Miss Joy, what would you choose?
we don't we want to see what's it called, the answers.
You don't see the answers?
The answers, I only see A. The other one, they
Oh, I can
cover up
see it. Okay, hold on. What about now?
tiny bit more. I'm not gonna see the answer. You can, you can move it a little bit
Okay, hold on. Hold on.
just to see the D. Okay.
Oh,
Right here, right here, right here, right here. Oh,
okay, guys. So the correct answer
B or A?
is A. Yes. So the correct
what?
answer is A. So water will kind of dilute the electrolytes. Okay, so this is a tough question, but when you irrigate an NG tube, you want to use sterile saline, okay? Because that's going to avoid the dilution or depletion of the electrolytes from the water. Tough question. And there's other questions here that I feel like, like this one, like right away. This is something you could see. Okay, 19. Can you guys see all the choices A to D?
No.
What about now?
Kind of.
Yes.
Yes.
Okay. 19. The nurse writes the following nursing diagnosis for a client in acute renal failure. Impaired gas exchange related to, this is a good question.
D.
Okay.
Mm. Uh, oh, maybe A. Sorry. A.
Okay.
Not
So we've
fluid.
got an A.
No,
Anyone else?
I'll choose D.
I can't really see D. That's why I can't pick it up because
Okay.
it
A.
cover up a tiny bit.
D says decreased production of renin.
Mm.
I think it's A.
It's A. I'll pick A.
Very good. Very, very
Woo!
good.
Yeah, actually.
Okay. So the kidneys make something called erythropoietin. So this is how it's spelled, erythropoietin. So the kidneys are supposed to make something called erythropoietin. And erythropoietin stimulates the bone marrow to make red blood cells. So if the kidneys are in trouble, like an acute or chronic renal failure, you're going to have decreased erythropoietin. So therefore, you're going to have decreased red blood cell production. And that's going to lead to anemia. And because so you need red blood cells because red blood cells have hemoglobin on the inside of them. You need hemoglobin to carry oxygen. So
Mhm.
the less erythropoietin you have, the less red blood cells you have. The less red blood cells you have, the less hemoglobin you have. The less hemoglobin you have less oxygen carrying capacity in your blood. You have less hemoglobin to carry the oxygen molecules. So that's a gas. Oxygen is going to cause impaired gas exchange where you don't have enough oxygen to exchange to the tissues. Okay.
Miss Alexandra, I have a question.
Mhm.
What's the difference between a splint and the kidney?
Can you say the first part again?
Okay, what's the difference between the splint? Am I saying it right? Splint? I think it's splint
Oh,
and
okay.
kidney.
Okay. So the spleen is part of the lymphatic system and like the immune system. The spleen kind of like it takes the old red blood cells and destroys them.
Okay.
Okay. And
Thank
then
you.
the kidneys, you're welcome. And the kidneys are like two Brita
Filter.
filters. You know, like the Brita filters you attach to the sink?
Mm-hmm.
And
Mm-hmm.
it takes water in and it gives you filtered water out, or
Mm-hmm.
the kidneys are like two filters. They take all of your blood and filter out all of the waste in
Mm-hmm.
your blood, and from the waste is going to make urine.
Mm-hmm.
Okay.
Mm-hmm.
So that's
So,
the
So
Professor,
technically,
for this
the splint
question,
just do a little bit of the kidney work, but the kidney do the most. Is that am I getting it right?
No, the spleen is more like it digests old red blood cells and it
Mm-hmm. Mm-hmm.
helps with like the lymphatic system as well.
Mm-hmm.
So like somebody with like somebody with like a severe infection or something, they might have like an enlarged spleen because it
Mm-hmm.
deals more with like immunity and the lymphatic system. Mm-hmm.
Mm-hmm. Okay, awesome.
Yeah,
Thank you.
you're welcome.
Mhm.
so
So
Professor, I have I needed to clarify this. So, for the later part of this question, for now that I'm looking at it, the red blood cells, most of its function is to carry gas. So the renal part has nothing to do with it, only the part that says impaired gas exchange. That's what related it to the red blood cell.
right, because what relates it to the red blood cell is that the kidneys have to make erythropoietin. So the
Mm-hmm.
erythropoietin can stimulate the bone marrow to produce more red blood cells. So because the kidneys are damaged, the person will have less erythropoietin, less red blood cell production. So the less red blood cells the patient has, the less hemoglobin they have. You need hemoglobin to carry oxygen. You cannot carry
Yeah.
oxygen in the body. So because you have the kidney problem, not enough erythropoietin, not enough red blood cells, not enough hemoglobin, you don't have enough oxygen carrying capacity in the patient's body. So when it's time for gas exchange, when the red blood cells are in the capillary beds, they cannot give enough oxygen to the tissues because there's just not enough red blood cells.
Okay, yeah.
You
Okay,
see, so
thank
that's
you.
how it kind of ties in. You're welcome. So, but now this, guys, if you want to pass, you know what? After question 20, we're going to take a little break and then we're going to talk about acute renal failure and chronic kidney disease. If you want to pass your exam, you have to know those two diseases very well. And you have to know the medications you have to give for them. So we're going to review that, okay? All right, guys. So let me
Miss
see.
Alexandra, which one you say if we want to pass, we have to know well?
Acute kidney injury and a chronic kidney disease.
Oh,
Okay, so you have to know the difference. Okay. All right, guys. So now let's do one more question. We're going to take a short break and then we're going to talk about those diseases because that's important. Okay. A 6-year-old child returned to the surgical floor 20 hours ago after an appendectomy for a gangrenous appendix. His mother tells the nurse that he is becoming more restless and anxious. Assessment findings indicate the child has atelectasis. Oh, this is a tough one. Appropriate nursing actions would include. Oh, darn it. I showed the answer.
yeah.
Okay, so what do you think the answer is? And D is over here, like it's missing a space, by the way.
Okay. Gangrenous. What's a gangrenous? Gangrenous appendix?
B.
B as in boy or D as in David?
B as in boy.
Okay, so we've got one B.
As soon as possible.
See,
I can't see the D, so
Cough and
since I can't see
noise.
D, I'm gonna go with C.
Okay,
This
the
is
D is
tricky.
here. Yeah, I
D.
highlighted the D for you.
Where's
Remaining with the
that?
child and keeping as calm as possible.
Oh, okay, okay. Oh, okay, I see.
Mhm.
And the chance. Keeping. We don't see the rest.
see,
Keeping the child.
Yes, and this is such a tricky question.
Yeah, very tricky.
What's the rest? Is this says remaining with the child and keeping the child? What's the rest?
As calm and quiet as possible.
Mm,
C. C. I think it's C.
I would have take
Very
C.
good.
Yeah, C.
Very good. So having the child to turn, cough, and deep breathe would be the most helpful. You know, giving pain medication, that's not going to help. So, you know, this patient, would you consider this patient a post-op patient? Yes or no?
yes.
Yes. Why? Why
Yes.
would you consider him post-op?
It says 20 hours ago.
Very good,
Determination.
very good. So
Yeah.
that's a post-op patient. Remember the major complications post-op. I mean, besides like airway problems and bleeding, you know, really as nurses, we want to prevent two major complications in the post-op patient. We want to prevent post-op DVT and we want to prevent post-op pneumonia. So
Post-op.
when somebody has atelectasis, the alveoli, the grape-like sacs where gas exchange happens in the lungs, they become either filled with fluid or they become smushed flat. So that's why we want them to cough and deep breathe because that will help to keep the alveoli open. Okay,
Mhm,
so the correct answer is C. You know,
mhm,
and as a nurse, because it says he's restless and anxious, I automatically think we need to check his pulse ox to see if he needs oxygen. Okay, so
mhm.
also keep that in mind. When the question says your patient is restless, You want to check their pulse ox to make sure they're not hypoxic. You also want to check their blood sugar to make sure they're not hypoglycemic. So the anxiety is from the restlessness, and the restlessness could be from hypoxia. So please keep that in mind as well. All right, guys, let's take a 5-minute break. And when we come back, we're going to talk about the difference between acute kidney injury and chronic kidney disease. And then we'll do some questions on that. All right, guys, so first we are going to talk about the different stages of kidney disease, okay? So first you have to understand that when there is an insult or injury to the kidneys, maybe it's something that decreases the ability of the kidneys to get oxygen, and we're going to learn about that. Or it could be a problem within the kidneys itself, like an obstruction, or it can be in a problem after the kidneys, which we will talk about, like maybe like a kidney stone or something like that. So when you have a primary insult to the kidneys and it kind of reduces kidney function, that is called acute kidney injury. Okay, now what is very important to know is that acute kidney injury is reversible. You can reverse the cause of acute kidney injury if you can identify what caused it. Was it because the patient didn't have enough fluid volume because of dehydration, right? Was it because of a kidney stone? Was it because of some type of infection or something? If you can identify the cause and treat the cause, you can reverse acute kidney injury. However, if you do not reverse it and the acute kidney injury persists, it would lead to a chronic and progressive deterioration of kidney function. Make sure you understand that chronic kidney disease has no cure. You can only manage it. And chronic kidney disease is progressive. That means once the patient begins down that path, their kidney function progressively worsens. So if we do not identify and treat the cause of acute kidney injury and the cause and the insult to the kidneys persist, it will lead to chronic kidney disease stage 1, stage 2, stage 3, and stage 3 has 2 stages. Then stage 4, and then finally chronic kidney disease stage 5 is called end-stage renal disease. When someone has end-stage renal disease, they either need a kidney transplant or dialysis to stay alive. One of the major causes of chronic kidney disease is hypertension. Hypertension, for some reason, decreases blood flow to the kidneys, and it damages them, and it can lead to the kidney shutting down altogether. End-stage renal disease. Okay, so first up is learning about acute kidney injury, okay? Acute kidney injury is a rapid loss of kidney function. So anytime you're dealing with something acute, this is rapid onset, right now. Chronic is more like long-term, something slowly happening. Acute kidney injury is a rapid loss of kidney function. The problem is something is reducing blood flow to the kidneys, okay? And this leads to hypoperfusion, because remember, if something decreases blood flow, we're decreasing oxygen. So the kidneys are receiving less oxygen. This over time is going to cause the cells to die. And because you have cell death of the kidney cells, you have decreased renal function. Okay, so you have to know the 3 major causes. So the 3 major causes of acute kidney injury are classified as pre-renal, intrarenal, and post-renal. Okay, so let's look at a picture. Pre-renal, intrarenal, post-renal. Okay, so pre-renal means before the kidneys. Something is happening that's before blood is getting to the kidneys, and it is leading to acute kidney injury. Intrarenal, the kidneys are the blame. There's something within the kidneys, like an obstruction, like a tumor, a stone within the kidney that is causing a decreased renal function. Post-renal, it's something after the kidneys, like if a kidney stone was stuck in a ureter, extremely painful, or something wrong with the bladder, like a bladder tumor, or the bladder is not emptying and urine is going back up the ureter. Okay, acute kidney injury, pre-renal, intrarenal, and post-renal. So I want you to look at this picture again, and I want you to tell me what is highlighted in pre-renal. What body structures are highlighted? In this picture right here.
The heart, the aortic process is going down. That feeds your kidneys.
Beautiful, beautiful, beautiful. So in pre-renal, or things that are associated with pre-renal acute kidney injury, it is usually because of the heart. And when we're talking about heart and blood vessels, we're talking about fluid volume. Okay, so remember, your kidneys need oxygen to stay alive. How do we get oxygen? Does oxygen like float around on its own? Or is oxygen like attached to something? What is it attached to?
Oh, delivered through the blood.
Through the blood inside what? But is it just like floating molecules of oxygen just floating in blood? Or is it attached to something?
Hemoglobin.
Hemoglobin, right? So when we have low fluid volume, we don't have enough oxygen getting to the kidneys. Okay, so like let's say our dehydrated patient who hasn't drank enough water, or a patient who's losing a lot of blood because of trauma. So when we have low fluid volume, we have a low perfusion of the kidneys. So if the kidneys don't receive enough oxygen, they can't work. Okay, so pre-renal causes of acute kidney injury usually deal with low fluid volume. Either the patient is not drinking enough fluid and they become dehydrated, and that's why they're not going to pee a lot, or something is causing them to lose fluid volume, like they're bleeding out. Okay, so next up is intrarenal. Okay, so pre-renal is before or outside the kidney, and it is caused by intravascular volume depletion. Fluid volume is low. When you have low fluid volume, you have decreased renal perfusion. Okay, so some causes of intravascular volume depletion: blood loss, okay, pre-renal infection. Intrarenal, it's within the parenchyma, within the tissues of the kidneys, like tubular necrosis, ischemia, or intrarenal infection. Then you have post-renal causes, like some type of obstruction, like with a kidney stone or something. Okay, so what do you need to know? Okay, what do you need to know? Make sure you know acute kidney injury is reversible. Okay, so the best action for acute kidney injury is to find the cause and treat it. So this usually deals with IV fluids and Lasix. Okay, so make sure you know that. Okay, so now let's go back to this. Okay, so you have different phases of acute kidney injury. First, you'll have the onset, which is when the issue occurs. Then you're going to have the oliguric phase, where urine output is going to drop. Then you're going to have diuretic phase, where when we treat the problem, urine output is going to rise or increase. Okay, so some interventions when you're taking care of your patient with acute kidney injury. Number one, you want to monitor their daily weights. So remember, your kidneys are like filters. They remove the waste and excess fluids from your body. So you want to monitor their daily weights, because if kidney function is worsening, they're going to retain more fluid. Does that make sense?
Yes.
Okay. Very good. You're going to monitor for acidosis. The kidneys remove the acidic wastes. from the body. So when the kidney function is worsening, you're going to have a buildup of acid. Okay. Also monitor the lungs for wheezing and signs of fluid overload. Okay. So now we're going to get into chronic kidney disease. Okay. So chronic kidney disease is slow and progressive and irreversible. Acute kidney injury was a rapid onset. If we find the problem, we can reverse it. Chronic kidney disease, this is over months and months and months. Slow, progressive, and it's irreversible. Once it starts, you cannot stop it. Okay? What they use to monitor the severity of chronic kidney disease is something called the glomerular filtration rate. Okay? In someone like in their 30s, glomerular filtration rate should be like 125 mLs per minute. Glomerular filtration rate is how much blood your kidneys can filter in 1 minute. So in a healthy 30-year-old, their kidneys should be able to filter through 125 mLs of blood in 1 minute. By the time you turn 65, your GFR will naturally decrease to 65 mLs per minute. Someone with chronic kidney disease for the last 3 months or more, their glomerular filtration rate has been less than or equal to 60. Okay? So their kidneys don't function as well because of an issue that has damaged their kidneys. So the common causes of chronic kidney disease is acute kidney injury that did not get treated. And usually you will see that a lot with the elderly who constantly have UTIs that causes acute kidney injury that leads to chronic kidney disease. Okay. Also diabetes. Diabetes ruins the kidneys. Okay. It's called diabetic nephropathy. Okay. So untreated acute kidney injury can lead to CKD, diabetes, hypertension, chronic urinary obstruction, recurrent infection. Okay. So assessment is very important to know the assessment of chronic kidney disease. Asterixis, which is like a flapping of the hands. Okay. We have ataxia, which is like a poor balance, poor coordination when they're walking. Inability to concentrate. Cardiac. Cardiac, what's important to know is they're going to have signs of fluid overload, which can be associated with heart failure. Respiratory for chronic kidney disease, crackles, shortness of breath from fluid overload. The kidneys are not removing fluid from the body the way they should. Hematological, somebody with chronic kidney disease is at risk for bleeding and anemia. So they're at risk for bleeding and anemia because their kidneys don't make enough erythropoietin and they don't make enough red blood cells and they become anemic. Okay. GI, I'm telling you, it's very important to know this assessment, guys. I'm not wasting your time. You have to know this. GI, they're going to have a very bad taste in their mouth, okay, like a metallic taste. It's from all the waste. Remember, guys, everything that's a waste, nature will tell you something is a waste either by the way it smells or tastes, right? Like feces, like your bowel movement, it smells bad. That's nature's way of telling you, don't eat that. That's full of bacteria, right? Waste products usually have a bad taste or odor. So because the kidneys don't work, all the waste products stay inside the patient's body and it causes a very horrible taste in their mouth. And because of that taste, they don't want to eat, which is called anorexia. And those waste products, it makes them very sick because your body's supposed to remove them. Okay. Also, they're going to have a very foul odor to their breath called uremic fetor. So anytime and then brushing your teeth will not fix this problem. Okay, it's very embarrassing for the patient. Anytime you hear the word fetter, is odor. Okay. Urinary. So it depends on where they are in the chronic kidney disease. As chronic kidney disease gets worse, they will progress to the point where they won't pee at all unless they get a kidney transplant, and it takes. Okay. Integumentary, I want you to know uremic frost. I'm going to show you a picture. So let me show you something. I know you've seen this before. You've seen this before, right? At the nursing home. So this is uremic frost. This is uric acid. Uric acid, that's where you would get the word urine from. Urine is uric acid. Okay. Anyways, I love this subject, but the word urine, we're talking about uric acid. That's what's supposed to be released, urine. So now your body tries to find other ways to get rid of the uric acid because your kidneys aren't working. So it does it through the skin, and when sweat evaporates, it leaves like a crystallization on the skin. So these are uric acid crystals because the kidneys can't remove it naturally. Your body tries to find a way to get rid of it. So, this is embarrassing and, causes self-consciousness. Of course, we could take a washcloth and try to moisturize the skin, but this will still persist unless the patient gets some type of help with the kidneys, like dialysis or something. Okay. Next thing you know is musculoskeletal. They have a lot of bone pain because they're going to have low calcium. Reproductive problems, they're going to have decreased fertility. So women with chronic kidney disease have issues becoming pregnant. Men have issues with their sexual desire and erections. And women have irregular periods. So in all of this, patients with chronic kidney disease are very likely to have depression. Okay. So, some special problems when you're dealing with a patient with chronic kidney disease. Number one, keep in mind they're going to be very tired. Can you tell me why? Why would a patient with chronic kidney disease be tired? That's interesting. Why would a patient, can you tell me?
Inability to remove the waste naturally.
Beautiful. And then it goes back to erythropoietin. And so everything with chronic kidney disease goes back to erythropoietin. But, they're low erythropoietin, low red blood cells, low
You
hemoglobin.
anemic?
Yes. So because
Yes.
it's anemic, it makes them tired because they don't have much oxygen in their blood.
Right.
Yeah, so anemia naturally makes the patient tired. So they feel tired and it's really hard for them to concentrate. So and it sucks because chronic kidney disease, they have so much going on, they have so many problems. You're trying to educate them, but they're tired and they can't concentrate. So you have to teach them a little bit at a time. You teach them something, you ask them to teach it back to you, you give them a break. Come back in an hour or two. Let them rest. They're exhausted. Also, they're very likely to be depressed too, because you see, they have a bad taste in their mouth. They can't eat. They're conscious because their breath smells weird. They have the things on their skin. Now they need dialysis. It's a lot going on. Anemia, you know why? We treat it with epoietin alpha. Okay, so because they have low erythropoietin, we give them a man-made version, a synthetic version of erythropoietin, which is called epoietin. Okay, there's another one called DARB epoietin. Okay, This is going to do the job of erythropoietin. And also because they're anemic, we give them iron supplements, but make sure you know that it makes them constipated. Worst case scenario for bad and severe anemia is a blood transfusion. Okay.
Question: why do they always want ice?
Anemia.
Because they always thirsty, isn't it?
There's something about somebody who wants a lot of ice, they're anemic. And then I don't know why.
And Miss Alexandra, when you're anemic, it don't okay. Some people when they're anemic, don't they make them want to eat like things other people won't eat, like
Pika,
craving other things.
like
Like,
dirt and clay.
yeah,
Yeah,
yeah.
so that's the body's way. When your body craves something that's not food, like dirt and clay and freezer frost and starch, that's your body's way of there's a mineral in that weird thing they're eating that their body craves, and they just
Hey,
found a weird way to get it in. It's so
you
weird.
know,
But you know
you
what?
know what's so crazy?
Uh-huh.
Um, do you do y'all know why the ice strips people of iron, which makes them anemic?
No, I don't.
Well, see, when the water goes through into the solid phase, when it becomes frozen, there's certain nutrients that are shaved off, so the water is no longer healthy, and is no it no longer has its property of helping you to retain the iron that was once there, and it actually removes the iron from your bloodstream, therefore causing anemia. So it's kind
Okay.
of cool. Yeah, I learned too from like kind of off subject but on the subject of the water. Like in the plants, they remove a certain component from the water. So you still see liquid, but it's no longer water. And if it touches you, it burns you. It can burn your skin right off your bone. So it's crazy how that works.
Oh my gosh. Well, thank you because I'm telling you, like, I know that, thank you for that. Because I know that when somebody eats a lot of ice, they're usually anemic, but I never could understand why. And then I was reading in a book that said that not only when they want to eat ice, I don't know if it was a book or a study guide, I don't remember, but not only if they want to eat ice does it mean they have anemia, but it could cause anemia. I could never understand
I learned something
why.
new.
Yeah, but it's something about, but like he said, maybe it dilutes the iron in their blood.
Exactly what I was going to say. Yeah.
Yeah, it literally does remove the iron from it because I forgot what component it was, but when water turns into ice, it loses that component and it actually removes the iron from your body once you
Oh
consume.
wow,
Wow. Well,
that's a big one.
thank you. So I didn't even know. Thank you so much. Yes. So keep that in mind, guys. When somebody likes to eat a lot of ice, it could be because they're anemic and it could lead to anemia, like he said, because it could dilute the iron in your blood.
Well, I'm somebody nurse tonight.
Yes, that's right. Right. Very good. Very good. All right, guys. So hyperkalemia, just make sure you know. So now we're getting into like the really important stuff for chronic kidney disease, guys. Chronic kidney disease messes with their blood pressure, it messes with their electrolytes. Okay, so hyperkalemia. So make sure you know that damaged kidneys don't remove potassium the way they should. Okay, when the kidneys are damaged, too much potassium stays in the blood. So now this is awful because that paralyzes the heart muscle and it could lead to asystole. Okay, so this is why the patient is going to be on a low potassium diet. Okay, and also this is why we're going to give loop diuretics like Lasix. Lasix will help to decrease the potassium and actually,
Excrete it out.
huh?
Excrete it out.
Yes, beautiful. Yes. And also, Lasix is very friendly to the kidneys. Lasix is just like giving a kiss to your kidneys. It helps to promote kidney function. So it's like a double win. When someone has chronic kidney disease and they get Lasix, it's going to help to prevent hyperkalemia, and also promote kidney function. What we want to avoid is potassium sparing diuretics like spironolactone and triamterene, because these would increase the potassium level. Okay? So please remember, for hyperkalemia, okay? Now there's another medication I want you to know. Okay, so I want you to know these two ways to treat hyperkalemia. I know we said Lasix, right? But I want you to know the traditional treatments for hyperkalemia. So if your patient can swallow, you can give them polystyrene sulfonate K-exalate. If they cannot swallow or it's an emergency, they're not doing well, you want to give IV regular insulin plus dextrose. The insulin is going to open up the cell and let the excess potassium in, and it could lead to low blood sugar, so that's why we give the dextrose behind it. Okay? So please make sure you know these treatments for hyperkalemia. Polystyrene sulfonate K-exalate. Okay. Also, we could give Lasix. So the next electrolyte imbalance they're going to have is hypermagnesemia. They have too much magnesium. Surprise, surprise, loop diuretics will help with this too. Be careful, because some laxatives like milk of magnesia, magnesium citrate, like in the glass bottles at Walgreens and stuff, that could lead to hypermagnesemia in your CKD patient. Next up is hyperphosphatemia. So they're going to have a high phosphorus level. Okay, so we're going to treat this with phosphate binders. The one I want you to know is called sevelamer. Because we're short on time, chronic kidney disease, the phosphorus is high, we give sevelamer. Okay. Now remember, phosphorus and calcium are the opposites. So if phosphorus is high, what's going to happen to the calcium?
The calcium is down.
It's down. Very good. So because they have hyperphosphatemia, they're going to have hypocalcemia. So because the calcium is low, we're going to give calcium supplements. Okay. Also, hypertension, we have to watch their blood pressure. Why would they have hypertension? Why would somebody with chronic kidney disease have hypertension? That is weird, isn't it? Because their body is holding on to fluid, right?
Yeah.
Yes.
So remember, the kidneys are like those two filters that's supposed to remove waste and excess fluid from your body and make urine out of those wastes, and you pee out that excess fluid and those acidic wastes. But chronic kidney disease is not working. Fluid overload, hypertension. Because when there's too much fluid, the burden is on the heart and the blood pressure increases. So we give like antihypertensives, diuretics, okay? You want to look for the signs of hypervolemia, fluid overload. So monitor their intake and output to make sure that it matches, that what they're putting in, they're putting out. But if they're putting in and they're not peeing, diuretics, okay? Monitor for edema, like pitting edema. Monitor for hypertension. Monitor for signs of heart failure, like shortness of breath, the edema, wheezing, crackles, okay? Maintain fluid restriction. Most of the time, people with chronic kidney disease, they're on a fluid restriction. They get diuretics, low sodium diet. Why? Why would somebody with fluid overload need a low sodium diet?
Cause if you hyponatremia, it will keep the fluid in.
Beautiful, but why? Excellent, excellent. Tell me what. Okay, I want to tell you something.
So it's the opposite. Like if you
Okay, so check this
I
out.
just don't know. I don't know the way to say it.
It's okay. It's okay. So let's say you making some rice, right? And you put too much salt in the water. What are you gonna do?
You dilute.
Add water to it
And add water, yeah? What happens if you eat a bag of salty chips? What's gonna happen?
you're gonna be thirsty.
You're gonna be thirsty, and what are you gonna do?
Drink.
Water.
Drink water.
Drink. Guess what? Water follows salt.
Mm-hmm.
Yep.
Anywhere there's salt, water is naturally attracted to it.
That's a big
I
word.
was about to say that.
Yeah. So if somebody eats a lot of sodium, that's high salt intake, they're going to retain more fluid. And that's going to make the fluid volume overload worse. That's going to make their hypertension worse. Does that make sense?
Yes.
Yes.
Okay.
You know what I do? You know what I do, Professor?
Uh-huh.
I I visualize the salt as like a little cube or like a sponge, and when it's present there, any water that's around it sucks it in. The same as rice does
That's right.
when you it sucks it all in. So that helps me remember.
That is 100% right. You see, you guys think like true nurses. Very good. I'm telling you, you guys have what it takes. Yes. Okay. So, these are some major problems with chronic kidney disease that I suggest you should feel comfortable with this. Now, hypovolemia, I know you're like, well, what? That doesn't make sense because they're a risk for hypervolemia from fluid volume overload. Hypovolemia is more like after dialysis. After dialysis, because they had all that fluid removed, they're at risk for low fluid volume. Okay. Also, infection, chronic kidney disease, it suppresses the immune system. Also, remember they're not eating well because of the nausea, vomiting. So they're malnourished, their immune system is down there, and then if they have some type of dialysis access site, especially peritoneal dialysis, oh Lord, the infection risk is so high. Okay. These people are going through it. Oh my gosh. Okay. Um, okay. And then pruritus, their skin could be itchy because of those crystals as well. Okay. So now let's quickly, like, I don't know how quickly we can do this, but let's just quickly talk about dialysis. Okay. So you have two types of dialysis. You have hemodialysis and you have peritoneal dialysis. Okay. So hemodialysis is dialysis of the blood, right?
One of them you have at home, one of them you have at the facility.
Exactly. Very good. Where is this? So you have hemodialysis of the blood and peritoneal dialysis, which deals with like the fluid in the peritoneal cavity. So there's different access sites. You have central lines, AV fistulas, AV grafts, and then you also have peritoneal dialysis. So I don't want to overwhelm you with a whole bunch of information. So I'm just going to keep it straight, like the little tips I can give you that you can use for your exam, okay? So for a central line, they usually do this like it's an emergency, like the patient came in and they need dialysis like immediately. They're going to put a central line in. But just know that if a patient has a central line for dialysis, you can only use it for dialysis. Okay. Very rarely the doctor will give you an order that you could use it to draw blood, but just keep that in mind. Okay. And just know it's temporary. Central line for dialysis is temporary. Then you have AV shunts, and then you have AV fistulas. So this is what we call an AV fistula, an arterial venous fistula. What's the meaning of the word fistula? Hmm? What does the word fistula mean?
Is it like
It means it's an abnormal or unnatural connection. Okay? So anytime you see the word fistula, it's an unnatural connection. So that means AV fistula, arterial venous fistula. A vascular surgeon has taken an artery and a vein and sewed them together. Now, The
Okay.
pressure, the high pressure in the arteries is going to make the vein become very large. And the vein will have a very large, tortuous appearance. That's why it looks all twisty like a snake. Okay, that's because the high pressure from the blood in the artery is going to dilate and enlarge the vein. And now that vein will be strong enough to withhold like the dialysis needle. Okay, so hemodialysis, the AV fistula is the best hemodialysis access. It's the best one. It lasts the longest. You could use it forever as long as it's functional. You could use it forever. Unfortunately, you cannot use it right away. Okay, so AV fistula is the best, is the most highly recommended hemodialysis access. Is permanent. Permanent. You just can't use it right away. Minimum, you need 3 months for it to mature. What the patient can do to help it mature faster is after surgery, once they're cleared by the surgeon, they can squeeze a tennis ball in that hand. It's going to help the skeletal muscles around the vein, help the AV fistula to mature faster. So while they wait for the AV fistula to mature, they will use a central line, okay, while they wait. The next one is called an AV graft, arterial venous graft. So you can see we use the synthetic graft like a loop of some type of plastic or something, and it's going to connect. So instead of sewing the artery and vein together, the surgeon will artificially connect them together, where blood from the high pressure artery will flow into the vein, and it will make the vein enlarge and engorge. Okay, so AV graft, you can use this right away, but there's a risk of blood clots and infection. So this is not the best one. AV fistula, this one is definitely the superstar of hemodialysis. So now let me see what else I want you to know about hemodialysis. I want you to know that before hemodialysis, you should weigh your patient and you should check their blood pressure. You want to avoid giving blood pressure medications before dialysis because their blood pressure is going to drop during dialysis. Okay? Next up is peritoneal dialysis. So peritoneal dialysis is where you instill a diacylate solution into the peritoneal cavity and you're going to let it sit there, which is called the dwell time. And then you're going to drain the fluid out, okay, through the catheter. All right, into a drainage bag. So what do I want you to know? So when you spike this bag with this, it's like a plastic needle. When you spike it, make sure you wash your hands and you put on gloves, because if you put bacteria into this bag and the bacteria sits in the abdominal cavity for 8 hours, you're going to give this patient peritonitis and they're going to die. Okay?
What?
Yeah, so make sure you watch. They won't die right away, but you're going to give them a really bad infection that could lead to death. So make sure you wash your hands and you put on gloves when you spike the diacylate bag. Okay?
So the blue one go in and the other one down, take it out. Is that what's going on here?
Exactly. And
Okay.
it's not at the same time. Like the blue one goes in and then like the patient can go to sleep. Like, the patient can learn how to do this all by themselves for a caregiver. Then they go to sleep for like 8 hours. That's called the dwell time. You're going to let it sit in the abdomen, okay? And then you're going to drain it out into the drainage bag. So I want you to know the drainage bag always has to be below the level of the abdomen. Because if you have it high up, this waste can go back into the peritoneal cavity and cause peritonitis.
So basically, Miss Alexandra, it's just a cleanup.
Yeah, that's it.
Okay.
That's
Okay.
absolute. You're using this fluid to help draw out all of the wastes from the patient's bloodstream, like this picture. So all of the waste products is going to diffuse. Okay. Sometimes they call it like ultrafiltration. It's going to diffuse out of the blood vessel into the fluid in the peritoneal cavity, and then you're going to drain it out. So now, what I want you to know, keep this bag below the patient's abdomen, and I want you to look at the fluid. If it's cloudy, that indicates infection, okay? Also, I want you to know, if your patient has peritoneal dialysis, your number one concern is peritonitis, okay? So make sure you clean the insertion site with sterile technique. Also, if there's not enough fluid coming out, you can ask the patient when's the last time they pooped. Because if they're constipated, the bowels is going to press against this catheter and not enough fluid will come out. So you're going to be like, wait, I put a liter in, but only half a liter came out. Ask the patient when's the last time they poop. If they're constipated, that could cause it. Also, make sure you can move the patient from side to side. That can help to get the excess fluid out. So, all right, guys. So let's just do like a couple questions to wrap up what we learned about. Also, make sure you know that this solution, this diacylate solution, you don't put it in the microwave, okay? There's a special type of warmer you can use for this. And let me see, what else do I want you to know? Trying to think. Also, like, why do we warm the solution? Like, I know that cold solution would cause cramps, right? And that's very uncomfortable. But the real reason we use a warmer, and we use a special warmer for the diacylate solution, but we use a warmer because the more warm the fluid is, the more waste product it's going to pull out. Okay? All right. Trying to think of anything else. Oh, then the other thing I want you to know about the AV fistula. Who here knows what's the difference between bruit and thrill? Who here has heard of that? Bruit and thrill.
I have.
Okay, awesome. So how can you remember?
The thrill is what you feel, and the bruise is ooey.
Very, very good. So this is how I remember it. And this is in alphabetical order, and you just do A, B, P, T. Okay, A, B, P, T. You auscultate, bruit, and you palpate, a thrill. Okay, so please memorize this, guys. This is a common way they try to trick you. They want you to think like, oh, you palpate the bruit. No, you auscultate the bruit. That means you hear the bruit with your stethoscope. So if you put your stethoscope over like an AV fistula or an AV graft, you should hear a turbulent blood flow. And that's how you know that the fistula or the graft is patent, it's open, it's working. And then you should be able to put 2 fingers over it, and you should feel like a very hard to palpate, like a sensation, like a thumping. You should feel it, like your fingers should kind of jump up a little bit because it's just so powerful. So that's the thrill. So you auscultate bruit, you palpate a thrill. So that's another thing they try to trip you up. All right, guys, let's do some questions. And yeah, okay, hold on. Okay, 37. A client is to receive peritoneal dialysis. To prepare for the procedure, the nurse should
One or four.
So what type of dialysis is the patient getting?
Hemo.
Huh?
Robert said hemodialysis.
So let's read it again. A client is to receive peritoneal dialysis.
I'm sorry, I
It's
didn't hear it fully.
okay. It's
Okay.
okay. So they're getting the one with the catheter in their stomach. So which one of these answers is wrong?
Oh, which one is wrong?
Can you palpate for bruit and thrill with a peritoneal dialysis catheter?
No.
No.
I
No.
don't think so. No, it's a port. No, it's a port there, like a
Exactly.
basket.
So bruit and thrill, that's for AV fistula and AV graft from hemodialysis, right? So that's why
Right.
one is not the answer because
Okay, so it's the one with the two bags, right?
Sorry.
exactly,
I'm
yes,
sorry. Right.
The one
Yes,
with
that it should be 4.
okay, the one with the two bags. You warm it up on a warmer.
yes, very,
Yep.
very good. So do you see how they try to trick you right off jump? I'm telling you, any kind of question about dialysis, they are most likely going to try to trick you about the route. So bruit and thrill is for hemodialysis, and you have to remember
Shame on
ABPT, auscultate, bruit, palpate, thrill. So peritoneal dialysis, that's the one with the two bags, and you warm the solution to like increase the effectiveness of
To
the
move the
exchange
waste.
session. Yes.
And they do that one every night, correct?
Yep. Yeah.
That's what I thought.
Yeah. And they can do it from home. The problem is the risk for infection. Okay, 38. A client has been admitted with acute renal failure. What should the nurse do? Select all that apply.
Get over here. So, gotta get back on it.
So would you elevate the head of the bed? Yes or no?
That's good.
Yes. Why?
Mm,
Because patients with
Take-
acute renal failure or kidney
probably.
problems, are they at risk for fluid overload?
Yes.
Yes.
Yes. So you want them to be sitting up. Should you take their vital signs?
Yes.
Yes.
Yes, very good. This is a new admission. You always want to assess your admission's baseline vital signs. Do you want to establish an IV access site?
Yes.
Very good. So this is a new admission. They have acute renal failure. We need to be able to give them medications rapidly. What about call the admitting physician for prescriptions?
No.
Mm, no, but it looked like the last one though. Contact the hemodialysis on it.
So are we going to say no for 4 or yes or maybe?
No for me.
So what do you think the word prescriptions means? Like, do you think like it just means like bringing a paper to the pharmacy to get medication, or do you think prescription means orders?
It's
Waters.
others in the
Orders.
profile of the
Okay.
others in the profile.
Yeah, so orders like so we need when a patient is newly admitted, right? We need some type of orders because that's what we're gonna base our care off of, right? Like so we base our care off of our assessment and then after that we call the doctor so we could get some orders going so we can kind of like start to have a direction for this patient. So like acute renal failure, you welcome the patient, you do their vital signs, you do a head to toe check, you make sure that, they have the patient bracelet on, allergy bracelet, then you make sure you lock the wheel bed. If you put the call light in reach, you let the charge nurse know the patient is in this room and they're stable. You call the doctor and you say, hey doctor, this is a 72-year-old male admitted from the emergency room with acute renal failure. The vital signs are this, the head to toe. You tell them what problems you have. So what would you like? And then the doctor will say, okay, we'll go ahead and consult nephrology. And you know what? Because he's on Coumadin, go ahead and consult cardiology. I'll be there to see him in the morning. So you need to let the doctor know what's going on so you could get some orders to get the plan working. So 4 is correct. And then what about 5?
No.
Very good. Why? Because he has acute renal failure, right?
Mm.
Does acute renal failure need hemodialysis right away?
No.
No. Okay. So hemodialysis usually that's like for emergency situations when acute renal failure or for chronic kidney disease, that last stage. Okay. All right, let's go. Let's do a couple more questions here and then we're going to go to chronic kidney. 39. Which of the following is the most common initial manifestation of acute renal failure?
Would it be aglaria?
Yes, very, very good. So the most common first sign of acute kidney failure is oliguria, where the kidneys don't make enough urine. So just always keep in mind, if the kidneys don't get oxygen, they will not make urine. Okay, and so if there's not enough fluid volume, there's not enough renal perfusion, and then the kidneys don't get enough oxygen or blood flow to make the urine. Okay, let's do one more for acute, and then we're going to switch to chronic. A client developed cardiogenic shock after a severe myocardial infarction and has now developed acute renal failure. The client's family asked the nurse why the client has developed acute renal failure. The nurse should base the response on the knowledge that there was, what would you choose?
4. Structural damage to the kidney resulting in acute tubular necrosis.
A, one.
Why is it A? It's
The
A.
one.
Good.
Decrease
Oh,
in
right.
the blood
And then
flow through the
I'm
kidney.
sorry.
It's okay. It's all right. So very good. A decrease in the blood flow through the kidney. So just remember, so that will be like pre-renal acute kidney injury where there's
Right.
low fluid volume. Okay. And
Go, Mike.
huh?
Oh, I was saying Mike. Go, Mike. Okay. Sorry.
No, it's okay. It's all right. The signal, the audio is not so good for me. I'm sorry, guys. Did you say myocardial infarction?
Happens in severe.
Okay. I don't know why I can't hear. But yes, so basically this patient had a heart attack, and so the heart attack probably damaged so much of the heart muscle that the heart couldn't beat effectively, and so it stopped beating, and that led to cardiogenic shock. And so shock is associated with a low blood pressure. So when you have a low blood pressure, you have low cardiac output. So let's look at this picture one more time. Hold on. Oh, not that one. Let's look at this picture one more time. So this picture, so your blood pressure is determined by your cardiac output. So cardiac output is how much blood is leaving that left ventricle and entering the aorta. And from the aorta, it's going to go to, you see the aorta, how it has the aortic arch and it goes behind the heart, and you have the abdominal aorta. So, and then you have your other major arteries. So from the aorta, that's where your body's going to get your oxygenated blood. So if you have like cardiogenic shock, where because of a heart attack, so let's say let me get the tool, hold on a second, and let me use yellow. Okay, so let's say the patient had a clot in one of their coronary arteries. So, and then that clot, everything below that clot, so I'm going to use yellow to show like heart muscle death, everything below that clot could not receive oxygen. All the heart muscle after that clot could not receive any oxygen. So that's going to lead to myocardial ischemia. And then myocardial ischemia that is not revascularized, reperfused, is going to lead to myocardial infarction, correct? Yes or no?
Yes.
Yes. So whenever there's a blockage in a coronary artery and it impairs the ability of that coronary artery to get oxygen to the myocardium, first you're going to have myocardial ischemia, okay? And then when you don't remove that blockage, that myocardial ischemia is going to progress to infarction, irreversible cell death. So now let's pretend that this whole heart muscle is not working because of infarction, irreversible cell death. So because that part of the heart muscle is not working, the heart cannot beat properly. Because like a fourth of it isn't working. A fourth of it just died, right? So the heart is not pumping effectively. So the heart can't pump. The heart stops. That's called cardiogenic shock, where the body goes into shock because the heart isn't pumping. The heart isn't beating. So that means you're going to have low cardiac output. So when you have low cardiac output, you have a low amount of blood leaving the heart. So that means you have a low amount of blood getting to the kidneys. So a low cardiac output is going to lead to renal hypoperfusion. Does that make sense?
Yes, it does.
Okay, so somebody with a heart attack that causes cell wall death of the heart muscle and the heart stops beating and they have cardiac arrest, cardiogenic shock, low cardiac output, low renal perfusion, and then you're going to have low urine output. So let's read that question one more time. So a client developed cardiogenic shock after a severe myocardial infarction and now developed acute renal failure. Now do you see why the decrease in blood flow is what caused the acute renal failure? Yes or no? So you see why one is the answer?
Yes.
Yes.
All right.
I know why. I know why I answered it wrong. My mind totally saw something else.
Well,
And
not only that, but you're driving across states through a hurricane, so I think we should consider that too.
but I should be a nurse regardless. Now,
Well,
right.
actually, you already are, and you answered most of the questions right. So
Yay! Thank you. That was motivation.
I think you're doing excellent.
Thank you.
You're welcome.
I had a good teacher.
Yes, because you're driving while you're answering. I can't even merge lanes. Like I'm fully focused and I can't merge lanes. So
Well, if you ask Noah, I'm not merging lanes well either. So
I merge lanes horrible. Oh
he
my
took over driving now.
God. But you guys are doing amazing, and please drive safe, guys.
Thank
So let's do a couple questions for chronic so we could kind of switch it up. So acute is more like, just like rapid changes, like a heart attack causing, decreased renal blood flow, So now chronic, let's see the difference. So a client with chronic renal failure is receiving hemodialysis 3 times a week. That's very standard. In order to protect the fistula, the nurse should, what would you choose? A client with chronic renal failure is receiving hemodialysis 3 times a week. In order to protect the fistula, the nurse should the nurse take the blood pressure in the arm with the fistula?
No.
you.
No.
No. Very good. Never, 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 because you're going to destroy the fistula. Should you report the loss of a thrill or bruit? Should you report the loss of a thrill or bruit?
Yes.
Yes.
Very good. So now let's see how they tried to trick you. What about auscultate for a thrill and palpate for a bruit?
No.
You should not. That's backwards.
Is there we yes, very good. So you're gonna take ABC order. A B P T. You auscultate a bruit and you palpate a thrill. Very good. So but do you see how they try to trick you? Okay.
Same
And
one.
then can you start a second IV in the arm with the fistula?
Oh no.
No,
No.
no,
So
no.
whenever there's a fistula, you cannot check a blood pressure in that arm and no IVs or blood draws in that arm because you can damage the fistula. And remember, if they have a fistula, they need it, obviously, and we want them to use it for as long as they can, okay?
Hmm.
Because we don't want them to run out of sites.
Yes.
Yeah, we don't want them to run out of sites to have a fistula
From
create.
here? Yes.
Who can access the fistula?
A dialysis nurse.
Yeah, I was told to ask that. So.
It's all right. It's all
Yes, I wanted him to access so everyone would know.
right. Yes, and that's good. Okay, 81. The dialysis solution is warmed before use in peritoneal. Oh, now this is the one. Okay, the dialysis solution is warmed before use in peritoneal dialysis, primarily to, what would you say, encourage the removal of serum urine?
Extra what? Extra, someone to help me. Extra waste.
Mm-hmm. So what would you choose? Now that you said that, what would you choose?
I could, yeah, first of them. Add extra one to the body. What? Um,
So we
I
said
would have take one. Encourage the.
yes, very good, very good.
Yeah, yeah.
So remember, we warm the dialysis solution. I mean, like one plus side of it is that because we don't want to put cold fluid in someone's belly. That's really uncomfortable, right?
Mm-hmm.
Right. But it will make the dialysis transfer more effective. You'll get rid of more serum urea because remember, normal kidneys would make urea into urine, but this person kidneys doesn't work. We're going to use dialysis solution to get rid of that acidic urea.
Mm-hmm.
Very good. Okay. All right. Let's see. Oh, this is a good one. Which of the following assessments would be most appropriate for the nurse to make while the dialysis solution is dwelling within the client's abdomen?
Monitor electrolyte.
There's something more important.
Oh, respiratory.
Yes. Why?
Cause of the fluid.
Yes. Very good.
It might cause.
So let's look at something.
I don't know the rest.
It's all right. So let's look at something. So let's look at, the thoracic cavity and let's look at the abdominal cavity. What separates the abdominal cavity from the thoracic cavity?
The diaphragm.
The diaphragm, right? So what do you think is going to happen to the diaphragm the more, like when we increase the pressure in the abdominal cavity? What happens to the diaphragm?
It goes up or
It goes up.
down.
And then so as we increase the intra-abdominal pressure, we push the diaphragm up. What do we do to the ability of the lungs to expand? The more we push the diaphragm up, aren't we making it harder for the lungs to expand all the way?
Yes.
Yes.
Right?
Yes.
And so, like when someone is pregnant, when they have peritoneal dialysis, the more stuff or fluid in someone's belly, the more it's going to push up on that diaphragm and make it hard for their lungs to expand. So, anytime your patient has something that will increase intra-abdominal pressure, I want you to think that it's going to make breathing more difficult for them.
Mm-hmm.
So like the most common thing, let me show you.
The best explanator on earth, Miss Alexandra.
Oh, you are so sweet. Thank you. Thank you.
You're welcome.
You guys make it worth it. All right. So, do you guys? I know we didn't talk about this yet in the review, but ascites. This patient like has cirrhosis, liver problems, and so this would definitely increase that intra-abdominal pressure, right?
Mm-hmm. A lot
So
of fluid.
yeah, and then as it fills up more and more, that diaphragm is getting pushed up more and more. It's gonna be more, especially if they're laying flat. Oh my gosh, let me show you this one. Ooh, now this is the one I use in the GI PowerPoint. Oh my gosh, can you imagine this patient laying flat and all that fluid is pushing up on that diaphragm? It's gonna be so hard for him to breathe, right?
Mm-hmm.
So anyways, long story short, when somebody has peritoneal dialysis and we're putting fluid in, monitor their respiratory rate to make sure they're not in respiratory distress. Because then you might want to sit them up, put them on oxygen.
Follow. What you call that position?
Like
You
Fowler's, yeah,
follow this. Follow position.
yeah,
No.
absolutely, absolutely. Okay, now there's one more. We're gonna skip this one because this one, you know, if the solution draining out of the peritoneal catheter is bloody, it could indicate blood vessel damage, and just call the doctor. Okay, that one is not common to see. Now, this one, yes, 84. During dialysis, the nurse observes that the flow of diacylate stops before all of the solution has drained out. The nurse should, what would you do?
Mm. Turn the client on from side to side.
Beautiful. Excellent work. Excellent, excellent. So remember, when you're trying to drain that diacylate solution out, if you put a liter, let's say for example, you put a liter in, you should get a liter out. But if you
Mm-hmm.
put a liter in and you only get half a liter out, turn them from side to side, and that can help. Like sometimes the catheter is like positional, like it depends on the position. So turn the patient, and that can help get the catheter in the right place and get the fluid going out the way that it should. All right, guys, you guys did absolutely amazing. So once this recording saves, I will send it to everyone, and we will meet back here next week, same time, same place. For those of you who have your exams tomorrow, I pray in the name of Jesus, you pass and you find.
Wait, tomorrow Friday.
Well, because it's
Wait,
already, it's already,
it's
it's
12.
almost 1 a.m.
Right. So it is. I'm sorry.
He still wanted to be Wednesday.
I know. Okay,
Right.
yes. In 2 days, well, let's see. Whenever you take it, I pray that you pass, and I pray that you find success. I cover you all with the blood of Jesus. I know
Oh, I
that will
receive
be
it in
our,
Jesus' precious name.
you guys will
Thanks for
be
studying with us.
good nurses. Yes.
Thank you.
God
And
bless you
may the
guys.
Most High done the same thing to you and your family.
Yeah. God bless.
God bless you guys. So I'm here if you need anything. So keep me updated, and I'll be back here next week. Okay.
Okay.
Thank
Spread.